Now, let me take you to East Africa for conversation on healthcare, if I may. Since the start of the year, Kenya has played up this idea of expanding universal access to affordable healthcare, but it's still not clear, A, what that is, or how this expanded healthcare will be paid for, especially at a time when, remember, the country is running budget deficits of nearly $6 billion. So private medical insurance, that also has taken quite a beating. In 2017, it actually fell for the first time in a couple of years to $384 million. Now, remember, that's about as much as what the state-run medical insurance firm, the NHIF, acquired in the same year. But this is also the first year-on-year decline since 2013, and the sector is bleeding money, $5.1 million in underwriting losses last year alone. On the public side, Kenya spends over $650 million every year on health services, and it's nowhere near enough. A proposal to raise more funds for healthcare through a tax of 0.05% on transactions over $5,000 was shot down in a very heated debate by legislators at the end of August. At the time, they argued this idea was ill thought out and it would suppress normal commercial activity. So then, at this point, with the lack of definitions and funding, of course, being pretty much up in the air, where do we go from here? That is a question that I put to my panel a little earlier. Dr. Amit Thakker, co-founder of Avenue Healthcare, current chair of the African Healthcare Federation, and Dr. Githinji Gitahi, who's a group CEO of the African Medical Research Foundation, AMREF. I started by asking them to define what an affordable healthcare package is and who should pay for it.
Universal health coverage is a journey, but starts here, starts with primary healthcare, where everybody in the country has equal and limited access to a package of care that is guaranteed to them that covers the primary healthcare services that is of adequate quality to provide expected outcomes. That's what it is. That if you go for malaria treatment, you'll get it without having to pay. If you go to deliver, you'll get it without having to pay. UHC doesn't mean that when you need an MRI, you get it. No, it means you first define what you can offer. Then you say, within the next 50 years, we are going to move towards providing you everything for free.
Dr. Thakker, your definition of UHC?
It's a very big overlap from what Gitahi said. It's enabling Kenyans to have access to health services wherever and whenever required without financial hardship. It's as simple as that. And they require quality care. I don't want to put in, I would say at the moment, I would say maybe we don't go into the details of benefits package and others, but without financial hardship is the way I would define it. And I think we're also emphasizing too much on universal health coverage. We should be focusing on what the Big Four agenda first came out with, affordable healthcare for all.
I'll get back to that in a moment, but we can't get away from the benefits question, because ultimately anyone who's listening to us will say, all right, it's all well and good for us to say we have a defined package of benefits, but what goes into that? Are we just covering infectious diseases, for instance, or are we going to cover non-communicable diseases, because cancer it's among the top 3 killers in the country at the moment, and we can't get away from that without talking about the cost element of it. What does it mean? Because let's be honest, there's 2-point-something million employed Kenyans in this country. Average monthly income is about 50,000 shillings every month. Who's going to pay for all of this?
In the kind of the spirit in Kenya, the benefits package have been moving is maternity care was the benefit package called Linda Mama. And that was agreed, and we provided that as a benefit package. We've agreed that under 5 treatment of children is part of the benefit package, no matter what kind of condition they have. They don't need to pay. We need to extend those benefits according to the costs that may be associated with those benefits. So the first idea is to cost those services. And since we don't have accurate data on costing, we are at the moment struggling with that design. But there's no doubt, since prevention is better than cure and cheaper than cure, primary healthcare should be our main focus so that people are treated right at the doorstep and in the first contact. And we should also be focusing on a population that has never accessed healthcare adequately in Kenya, and that's the poor.
I hear what you're saying about the problem about determining the costs, but here's how I'm approaching this problem. Every year, I look at reports from the Association of Kenyan Insurers, and the medical insurance guys will say, look, we're losing money on our premiums, left, right, and center. They all complain about, 1, premiums being essentially wiped out, but also 2, medical inflation. Year after year after year, the cost of medical care goes up. If these guys already have this existing pool of information that suggests that we have a fairly clear idea of what service costs in shilling terms, in dollar terms, at the point of delivery. Why can't we come up with a decent package?
The challenge that you're having with a private insurance is that the pool is very small to begin with. The pool is extremely small, and that small pool is then suffers two other principles. Suffers the principle of moral hazard, where many people buy insurance because they are sick, and then also suffers from fraud. I think the fraud level, Amit will probably have the numbers, is almost 30–40% out of the total money paid. A lot of it is actually fraud. That's number one. Number two is that there is no organized system. So insurers who are now buyers or purchasers for their members are dealing with individual doctors, individual X-ray providers, individual this and that, and the cost varies, and therefore they're also suffering from very high costs.
So essentially for them, they're suffering from price arbitrage, because if I'm a doctor, I can charge Resolution one price, I can charge Jubilee something completely different.
Yes, and that's why in some countries, they have actually pushed the medical fraternity to go into groups, into groups that then can negotiate. Then you bring down the cost of care. But I think also the challenge of the fact that they don't have a good pool also takes away their negotiating power. And that is why if the country can move towards a strategic purchasing agenda where we have a 100% pool of people with health insurance, whether it's NHIF or whoever else, then that particular pool becomes the biggest purchaser. Then it can actually force people to get on the table for negotiations on pricing.
An interesting debate there. We'll, of course, keep tabs on the healthcare debate in Kenya as it develops. Now, the only